Okay. Hi everyone. I'm sorry, I was just speaking and there was no voice. The mic was mute. So, God bless you, Amara. And yeah, definitely I'll try to revise some important things for you. So, I was asking just, okay. So, do students like my lectures there in Pakistan also? Like in India, I know the students do like. So, just tell me this question. What is this question on? Abhishek, wound? No wound, sir? Oh, no voice. Okay. Chalo. Let us start with this session. Tell me, what is this hernia? And just tell me, what is this hernia? This is very simple, very straightforward. So, what is this fascia known as? What is this gap known as? This is a Spigellian's hernia. This is a Spigellian's hernia. Spigellian's hernia. I'll give my love to all the medical students there. Yeah. Okay. So this is a Spigellian's hernia. Let us talk something about Spigellian's hernia and then we will discuss this MCQ also. So just wait. Let me go to this. Okay. Students, when we talk about Spigellian's hernia, one very important thing is what is it, where it is. So it is hernia. So it is hernia via Spigellian's fascia. So hernia via Spigellian's fascia. Yeah, FMG, Abhishek, the class, you're talking about the new batch. The new batch is going to start very soon in the month of April. Yeah, it's going to start. So let us talk about this Spigellian's fascia. Where do you get to see this Spigellian's fascia? Now try to understand what is this muscle. This is rectus. Let us take this muscle. This is rectus. Again, you all have to understand that the last layer in the abdominal wall. So external oblique, internal oblique, and we have transversus abdominis. We have transversus abdominis. So this is where the transversus abdominis is there. And you know this is ending at the level of arcuate line. Yeah. This is ending at the level of arcuate line. So if you appreciate, there is a fascia. There is a fascia here. What is this fascia known as? This is known as Spigellian's fascia. This is what is known as Spigellian's fascia. And hernia via this Spigellian's fascia. This is what is known as Spigellian's hernia. This is what is Spigellian's hernia. Now, do you know that what is the incidence? Where is it commonly seen? More than 80% of the Spigellian hernia, more than 80% of the Spigellian hernia, they are located infraumbilical. So they are located infraumbilical. So more than 80% of them are infraumbilical. Point number one. Why it is so? We'll see. Let us see. You can also see the maximum, the most common site is intersection, is the intersection of linea semilunaris, with linea semicircularis, Let us try to understand what is this. Let us see this. We all know that below the umbilicus, we have something which is known as arcuate line. And do you know, after the arcuate line, there is nothing known as posterior rectus. And this is the place where you have a potential defect. Let us try to understand that thing. Let us all try to understand. Bachcho, if you take this to be the umbilicus, if you take this to be the rectus muscle, yeah, take this to be the rectus muscle. Who is giving protection to the rectus? Anterior rectus sheath and the posterior rectus sheath. So this is external oblique. And do you know external oblique will form the aponeurosis? And where is this aponeurosis going to go? That form anterior rectus sheath. It forms anterior rectus sheath. The next is you have internal oblique. internal oblique will give one leaf to the anterior rectus sheath and one leaf to the posterior rectus sheath. Are you getting? So this is anterior rectus sheath. Then the last layer, we have transversus abdominis, and transversus abdominis is actually reinforcing the posterior rectus sheath, and this is how the anterior and the posterior rectus is formed. Yeah. Now this is above the level of umbilicus, As you go below the level of umbilicus, the scenario is going to change. So this is the linea alba we know. Now try to understand this. Students, external oblique, this is external oblique and it is going to reinforce the anterior rectus. This is going to reinforce the anterior rectus. Then we have the internal oblique. The internal oblique is again going anteriorly. Then we have transversus abdominis. The transversus abdominis is again going anteriorly. Are you understanding? Why? Because below the arcuate line there is nothing known as posterior rectus. Now students, if you see, what is this? This is a thin layer of fascia transversalis, and along with that we have the peritoneum. Can you appreciate one very important thing? There is a potential defect, isn't it? There is a potential defect, and you will not come to know that when the omentum incarcerates into this. So generally students, what happens at this level, this is external oblique, this is internal oblique, this is transversus abdominis, and all of them are contributing to this anterior rectus here. Anterior rectus, the peritoneum tends to invaginate, and hence the omentum might get incarcerated. Do you know this is a true intraparietal hernia? First of all, we have got to know why it is infraumbilical, because of the potential weakness. The second very important point that we all have to understand, that this is true intraparietal. What do you mean by true intraparietal? I agree to the fact that below the umbilicus, the posterior rectus is not there. But if you see the anterior rectus, it is more reinforced, and hence there is no palpable. Therefore, there is no palpable swelling. So there is no palpable swelling, and this is what is the USP. Are you getting this or no? No palpable swelling. So this is 100% intraparietal. Let us see what Shri has written. I am very confused between the scarpa fascia and Camper's fascia every time. Sir, would you please give me a diagram? Dekho, the Camper's and the scarpas. The camper is superficial, and then comes the scarpa, skin, subcutaneous tissue, and then you have the thin fascias. In the fascia also, S is not superficial, always remember. So it is first the campers, then the, you can say, scarpas, and then the muscles and the aponeurosis will start. Are you getting? So this is what is the concept of this intraparietal hernia, that is the Spigellian's hernia. So where is it seen? At the junction of, this is arcuate line. So at the point when arcuate line is intersecting, this is linea semilunaris, and this is linea semicircularis. This is the potential defect. Are you getting this or no? So potential space for defect. Next is, Bache, what will be the classical presentation of these patients? Let us try to understand what will be the classical presentation. The patient will present to you with vague pain. So presentation, it is pain over the abdomen. So pain around the umbilicus, over abdomen with no palpable mass. And many a times when the patient complains, we think that the patient is foolish, because once we examine, the patient is having no problem, no palpable mass. And then we say, you go back. But say your eyes will never see anything which your brain doesn't know. Investigation of choice is MRI abdominal wall. This is better than CCT. Why? Because in evaluation of soft tissue, MRI is best, is better than what CCT. What is the management? all Spigellian hernias, they require what? They require repair. They require repair. Are you getting this or no? They all require repair. So if you see this question, so they are mostly infraumbilical, absolutely true. Palpable expansile mass per abdomen, which is seen in conventional hernias, this is not seen. So this is false. Requires surgical repair, yes. But if we don't require a mesh repair, we simply go laparoscopically and take 2-3 bites in that gap, and this is done. It's hardly 15-20 minutes surgery. MRI is the basic investigation, absolutely true. So what is false? B. I hope this question is clear to everyone. Okay. Let us talk about the knot. Tell me. Identify the pattern of knot shown in the image. Identify the pattern of knot shown in the image. Tell me whether it is reef, whether it is granny, whether it is Aberdeen, or whether it is Melzer. Tell me what it is. Reef, granny, Melzers, or Aberdeen. Tell me what it is. So when we're talking about this, concept of knot, very good. देखो, this is a two-throw knot. Let us have a quick revision of the knots. Let us have a quick revision of the concept of knot. Let us see. Students, when we talk about the knots, we have knots in the open surgery and we have the laparoscopic knots. So open surgical knots and laparoscopic surgical knots. Okay. When we talk about open surgical knots, we have two-throw knots. In this two-throw knots also we have a symmetrical knot. What is this symmetrical? This is known as a reef. This is also known as a square knot. Important is this is a secure knot. So it is not going to slip off. When we talk about the another one, two-throw asymmetrical knot. What is this all about? Bache, this is known as granny's knot. This is known as a granny's knot. This is always, you have to understand, this is a slip knot. Therefore insecure, and therefore it requires extra hitch for security. Bache, then we have a surgeon's knot. What is a surgeon's knot? It's a three-throw surgical knot. Then fourth is Aberdeen's knot. What do you mean by Aberdeen's knot? This is loop out of loop knotting. Is that clear? Loop out of loop knotting. When we talk about laparoscopic knots, what are they? The first that we have is a surgeon's knot. The second that you have is extracorporeal slip knots. What is ECSL? This is extracorporeal slip knots. And we have two types of this extracorporeal slip knots. We have a Rodder's knot. This is 1-2-1. We have a Melzer's knot. So Rodder's knot, we have a Melzer's knot. Melzer's knot, if we talk about, it is defined as 2-3-2. And then I have my own knot technique, which I call it as SD's knot. I never use 232. I never use 121. I use always 222, and I call itself a SD's knot. This is my own modification. SD stands for my logo. Anyways, let us try to understand. This is a very simple concept that if you want to tie a knot, you have to exchange the threads. What do you mean by exchanging of the threads? Bache, I will have to take this right to the left and left to the right. This is what is known as exchanging. If two into symmetrical exchanges or cross, this is what is known as a reef knot. Bache, but the question is how to identify these knots on image. Identification. So reef versus granny is a very big challenge for you people. Reef versus granny is a big challenge for you people on image. So step for identification. The step 1. Select any one end. And then look for symmetry. If it is symmetrical, so look for the symmetry. If symmetrical, then that is a what, students? Then that is a reef knot. And if it is not symmetrical, then that is a granny's knot. Let us try to see this. In this image itself, if you get a question like this, select any one end. There are three ends. Suppose this is one end, this is second end, this is the third end. So if I see this end, the orange thread, the orange is below the blue. So orange is below blue. Here also, orange is below the blue. Can you see this is a perfectly what, students? A symmetrical knot. Here if you see, bache, both the blue are above. If you see orange is above, this is a symmetrical knot. Since it's a symmetrical, this is a what knot? A reef knot. So this is a reef knot. Are you getting this or no? But the basic idea of reef is, try to understand. If I take this as a thread, so this is the green end, this is the yellow end. Now if I want to tie a knot, I will have to cross. This is known as one crossing. Always remember, we will follow in order to create a symmetrical knot, we'll follow the order. If the green is coming from up, can you see, if the green is coming from up and then going like this, you need to maintain this symmetry. Now again green will be up and it is going to come from down. So if you see a knot in this is the similar knot that you are seeing. Are you getting? The two yellow on one side, two green on one side. Either it is above, the above layers are above, the below is below. This is what is a symmetrical knot, and the moment you tighten it, it will not get loose. So this is what is a reef knot. Now there are a lot of people who think that granny's knot is an incorrectly performed knot. No, not at all. But granny's is very useful knot, because many a time when we have to tie a knot at a deeper place, we want our knot to slip down to that place and get secured, because reef knot cannot be skidded. The moment you tie it, it will get locked. Are you getting? It's a locked knot. Now again try to see. This time the green is from up and then the yellow is from up. So what type of knot it is? It's a reef. And can you see I'm sliding it, it is not getting locked. Can you see it is not getting locked? And it will go to the desired point. And there, in order to secure it, I will tie one more knot. Are you getting? This is the beauty of a granny's knot. So granny's knots are actually again very useful for us, but they're utilized at places where actually you have to tie the knot at a deeper space. I hope this concept is clear. So this is a what knot? This is a reef knot. This is a reef knot. Again, there are a lot of questions. There are questions on the knots. So I'll discuss with you that question, just a minute. So I'll ask that question on the knot and I'll show you what is a what is this pattern of knot? What is this pattern of knot? This is loop out of loop knotting. This is loop out of loop knotting. And this is what is known as Aberdeen's knot. This is what is known as Aberdeen's knot. Aberdeen's knot. Yeah. This is known as Aberdeen's knot. Again, one more knot I will show you and I'll ask you. So, I'll ask you one more question. Tell me, what is this incision which has been made? Identify the incision made in this image. Identify the incision made in this image. Okay, so these are the incisions for the breast. And if you see this incision, this is an elliptical transverse incision. And when we talk about elliptical transverse, what do you mean by this elliptical transverse? This is a Stewart's incision. Stewart's incision. So let us try to understand the concept of these incisions. Whenever we talk about the incisions for the breast, incisions for breast, one very important thing that you all have to understand is what is the purpose of this, you can say, what is the purpose of these incisions? Okay. The purpose of this incision is aim. Either it could be cosmetic, either it could be for benign breast disorders, or it could be for malignancy. So if you are making it for malignancy, the aim should be exposure. Yeah, the aim behind the incision is what? Exposure. Aim to maximize exposure. And in order to maximize exposure, we will make elliptical incisions. Let us try to understand. What are the types of elliptical incisions that we make? We have elliptical transverse, and then elliptical oblique. Elliptical transverse, elliptical obliques. A question: which books are followed by your students? In India, we also follow the standard books like Saveston, Schwartz, Love and Bailey. When I teach them, I recommend them to read at undergraduate level Love and Bailey, and at PG level when they are pursuing the post graduation, I ask them to use the Mango for Mango abdominal surgery for the GIT. Along with that, if possible, they should be reading Blumgart, at least hepatobiliary part, some chapters from Blumgart, and Shackelford also in integration. But a baseline book for GIT, I will recommend Mango. And for other things like for general topics like breast, thyroid, I'll recommend Saveston and Schwartz. Both are equally good. General surgery part, yes, you can cover it from Saveston. Some part from Schwartz, and Love and Bailey is good. For urology, I will always recommend Campbell and Walsh for you people if you are doing surgery. If you are pursuing surgery, Campbell and Walsh you should be. For neuro, you should be using the Greenberg. This is what is the, you can say, advice at your level, that these are the books to be used. If you take my notes, they are, you can say, a comprehensive summary of all these books. Transverse, if you talk about, this is the tumor and this is the incision that we make. So this is what is elliptical transverse, and this is what is known as a Stewart incision. Again, if you talk about elliptical oblique, this is made for upper quadrant tumor. So, why the incision I am extending medially or extending with an arrow? That's all the incisions will ultimately lead to what? Axilla. Yeah, axilla. So this is odd incision. This is Stewart. You can join me on Unacademy. There are a lot of Pakistani students who have joined me on Unacademy. Yeah, you can join me on Unacademy because I don't teach at any other platform. Yeah, we have one more platform, that is preplatter NEET super speciality, where I have taught a lot of part, but not all, but majority of the things I have taught. Benign breast disorders, if you talk about, the aim is cosmesis, and therefore we try to minimize the size of the incision. Yeah, try to understand one very important thing, that here we try to hide the incisions with the natural contours. So this is circumareolar incision, and the circumareolar incision, this is also known as a Webster's incision. Yeah, Webster's. So one more incision is, you will lift up the breast and make the incision along the inferior mammary crease. So along the inferior mammary crease, what is that incision known as? This is known as Gaillard-Thomas. Amara, I actually teach regularly on Unacademy live. So many Pakistani students are taking my live, you can say, lectures on Unacademy. You can download the app, you can use my code Dr Dixit, and you can also access the special free lectures. So I've taught a lot of things there. So nipple areolar complex is off, bache, it is paired. We make the incision along the, like, take this Unacademy logo to be nipple areolar complex. I will make the incision around this. I will not cut it. Is that clear? So inframammary incision is Gaillard-Thomas incision. So for today, only this much. We'll meet tomorrow again, and we'll continue from here. I hope you enjoyed this session. If you enjoyed, do join the Unacademy Plus using the code Surgery Live, or you can also use the code Dr Dixit. Do follow me on Unacademy so that you don't miss any notification of my classes. So I hope you enjoyed. Do comment in the comment section about how you like the class. So till then, bye-bye.